Welcome to this parallel session. Today I'm Mario Possenti. I'm the Secretary General for Federazione Alzheimer Milano and Honorary Secretary for Alzheimer's Europe. In this parallel session we have five speakers. We will talk about COVID-19 and dementia using a couple of lenses. First of all, the emotional part of the disease of the COVID-19, what caused in caregivers, in persons with dementia, and also in carers. And also using technology and how technology could help or helped getting through this pandemic. So without further ado, we have five different speakers. The first speaker is Clarissa Giebel from the University of Giebel, from University of Liverpool in United Kingdom. So please, the floor is yours.
Thank you. Very much. I know you might have seen my face earlier, so I feel like I'm on stage again. But this has been one of our accepted abstracts. So now I'm going to delve a little bit more into depth about our care home research. So my talk is entitled Guilt, Tears and Burnout and the Emotional Impact of COVID-19 on Care Home Residents, Families and Staff. And from earlier on, you will have seen that this is really just focusing on the care home angle and how people have been affected on an emotional scale. So when we conducted our community-based research, as I was mentioning in April 2020, one thing we noticed when we did our follow-up interviews, so we spoke to people and had surveys with people in April 2020, but then again in June, July, one thing we noticed was that quite a few of the participants that were taking part, their relatives had suddenly, within that short time frame, had to enter a care home because they were deteriorating so much with their symptoms, with their emotional well-being, with their ability to manage their everyday functioning, cognition, etc. Now we know obviously there were lots of care home restrictions in place, and making that really difficult decision to then relocate someone into a care home has a huge emotional impact on the unpaid carers as well. So this is something that came out as kind of a side finding in our community-based research. So what we wanted to do, and what we were lucky enough to achieve, was to get some additional funding to really just look at the care home setting and how people were impacted on an emotional scale, but also their day-to-day lives, looking at unpaid carers, residents, and care home staff. Now, because of the restrictions, we were unable to actually speak to residents. Obviously, that's a limitation, but we gathered some information from the unpaid carers who had loved ones in care homes and from care home staff. So what we've done, again, we've done quite a lot of interviews remotely, and Dr. Carrie Hanna at the University of Liverpool has done most of those interviews. She's done a fab job. And I must say, this study has been the most emotional study we've done to date. I've done some of the interviews, I've analysed some of the transcripts, and it was really tough. So from a researcher perspective as well, we had to have some research support dealing with these really difficult findings. And I think that can sometimes be neglected as well, on top of those negative impacts. So this is again just kind of a highlight in terms of when we collected the data, and again, because that's a key impact on the findings. In that time period between October, November, and then March 2021, we had the vaccination rollout and the increased testing. And particularly in March that year, it was suddenly announced by the then English government, because it was differently handled in the 4 nations across the UK, that any care home resident can have one essential visitor. Just suddenly announced, care homes weren't aware of this. A few weeks later, any care home resident can have 2 essential visitors, because that wasn't allowed before. However, that wasn't really taking place. That caused a lot of issues as well. So we had a lot of information and findings from unpaid carers, but also from staff, how these different types of visits were handled. With a lot of those pod visits, so people were putting out plastic screens, garden visits when the weather was okay. But then we also had lots of care home staff who were saying, it's really difficult to facilitate all these visits, because usually you'd go into care home. I remember going to care home and seeing my grandma whenever I wanted to before the pandemic. We don't have to have a care home member there. It just, again, takes off time off their schedule of caring for someone else. We have end-of-life care visits. Those were the only visits where people were sometimes allowed face-to-face into the room and allowed to hold the hand and give them a hug. But again, it was all really, really difficult. And then sometimes we noticed, because there was no overall guidance in place, and we know from work with our Dutch collaborators at Maastricht University, they had these guidance in place very early on a national scale in May 2020. We did not. So every care home tried to manage themselves, implement guidance however best they thought was working. And we had quite a few quotes from care home staff across those 16 care homes where they said, well, I'm noticing that Mrs. X is deteriorating. She's not eating anymore. She's feeling really unwell. We can tell she's really depressed. So we're allowing, on this specific basis, for her son or relative to come in for visits. But these were individual decisions based on individual staff. There was no guidance for this. But again, that shows also kind of the human decision angle there that care home staff was working on. And overarchingly, there was a severe lack of communication. There was that really big lack of communication from the government. So, for example, with the essential visitor status or guidance on visits or how care should be delivered, no communication. But there also seems to be a lack of communication between the care homes and the family carers. Sometimes there were some newsletters, for example, or emails being circulated, but relatives were really struggling to find out, how is my mum doing? How's my dad doing? I'm struggling, I can't get a visit in, and I can't really communicate with you. And again, all of this piled on top of one another, over from baseline to follow-up interviews in particular, that led to that moving from frustration to the anger in relatives. I spoke about that a little bit earlier, but it was really precise how we saw in those interviews. People were really agitated in those interviews, the family carers. They were like, I can see COVID is still making it into the home, but I can't go in. I can see the care home staff is going in. So there's just this build-up of poorer mental well-being and lower levels of support for the family carers. That wasn't really addressed, not by the government, not by any support systems. And then there was the guilt. And now I don't know whether you can really see the quotes. I hope you can a little bit. But lots of the unpaid carers were saying, I feel incredibly guilty. And we know from the unpaid carers that were part of our research team, so they helped us shape all the aspects of the project and analyzed some of the transcripts as well, that they felt guilty of having their relative move into a care home before the pandemic already, because they felt, well, I can't cope anymore, but I need to have some additional support. But on top of that, the pandemic, knowing that you won't be able to see your relative, but still effectively having to get that extra support in a care home, that made the unpaid carers feel so guilty. We have lots of quotes for that, and they felt they were abandoning their relatives. But we also noticed quite a few relationship breakdowns. So I was saying a few slides earlier about that lack of communication between the different organizations, institutions, individuals. We noticed a lot of breaking down of relationships between those different individuals and between that kind of triangle, so residents, families, care home staff. So, for example, between the families and residents, because the residents had dementia that we were talking the carers to, they didn't understand, why can't my grandchildren come in and give me a cuddle anymore? Why can't I see my husband? Why can't I see my wife anymore? It was difficult to understand, so they felt abandoned themselves, which they weren't, because unpaid carers couldn't come in. But there was also the breakdown between residents and staff we noticed quite a bit, and this is a quote from an activity coordinator. So at least towards the earlier stages of the pandemic, and still, I suppose nowadays in some regards, you have the masks, you have the aprons, and particularly for someone with cognitive deficits, you cannot see if someone's smiling, or you can't get that hug from a care home staff, which effectively is a second family to them, so they don't get anything. And that's But that's not just difficult for the residents. It's difficult for the staff as well. They can't act their normal role in the care home. And also relationship breakdowns between unpaid carers and care home staff. As I was saying earlier, that moving from frustration to anger, so people weren't engaging much anymore. And I know I've had that slide earlier, but just it's a really key thing, that carer burnout, and it's not just in staff, it's in unpaid carers as well, and we all really need to be mindful of this has had such a huge impact. What is it now? We still don't have that support in place to support paid carers and unpaid carers. We have loads of numerous quotes of that burnout being perceived. And here's just, I'm sure we're all aware of it now with the different changes in job roles. So we had increased hours of care working, and I was just mentioning as well about facilitating those visits. And it might still be in place in some care homes, but taking that time away from being able to care for someone, instead you need to sit next to someone, facilitate a garden visit, facilitate a remote FaceTime visit or something. It all takes time away without any guidance, as always. And we had noted lots of staff sickness as well. So one thing we've done with those findings, they're published now, but we wanted to take that next step, especially including our unpaid carers and our care professionals and charities that were involved in this project, was to take that next step, and we wrote a policy briefing. Again, this is with the Liverpool Heseltine Institute, and they've done a lot of series of kind of impact on COVID and the recommendations, but not just impact on COVID then, but how do we move forward from it? And we know now that if there's another pandemic, when there is another one, we know now it doesn't work just to cut off social interactions. We've done that learning now. It's been detrimental to everyone. So what can we learn from it? But there's also a podcast where I talk to a lot of people in the sector in a more engaging way, I suppose, than just reading a research paper. So we're really trying to engage with the findings as much as we can. And just the last couple of slides, mentioned that earlier, we're doing follow-on work on the mental health needs. And yes, really to say thank you to everyone who's participated, and it's been a really big project with everyone, so thank you very much.
Thank you, Doctor. Thank you. You can, as you want. You can stay here if there's a question from the floor. Okay, online there's none. I have a question. In your opinion, how is it possible to rebuild those relationships between the staff, the professional staff, and the caregivers? You know, there's a trust relationship. It should be a trust relationship between them. Is it possible to rebuild, and how this path could be, shared with other countries?
I think it definitely needs to be rebuilt, but it seems to be more of an approach from each manager of the care home, so they really need to be facilitating this. Maybe it's a drop-in session once a week or something, have a chat with our care home staff, but there needs to be much more of that engaging, and like we see at this conference, it's so much better to see each other face-to-face and not have miscommunication over email. We need that one-on-one with people to meet together, yeah.
Thank you very much.
Thank you.
So our second speaker is Marianna Tsatali. Sorry. She works for Alzheimer Hellas, and she will talk us about emotional function, adaptability, and negative thoughts in COVID-19 pandemic, dementia and caregiver self-reports.
Hello, everyone. I'm really happy to be here with all of you. In the first on-site conference after the pandemic. In Greek Alzheimer Association, where I work as a psychologist, we implemented some interventions, digital interventions, during the quarantine imposed. So, especially those delivered in caregivers are of our topic today to discuss. Before, moving to the agenda, I would like to say that we have published this research, so you can find it if you want to read some extra details. So, in this presentation, I will talk you briefly about some theoretical issues of our research design, and we will move forward the results and also see the future endeavors. So caregivers of people living with dementia are otherwise at greater risk of having poor mental health indices because there are already existing problems in this population by means of increased levels of fatigue, anxiety, stress. So the whole situation has been extremely deteriorated due to the quarantine because their lifestyle changes, there were increased levels of depression, anxiety, and of course, so other many health measures which were also deteriorated. So some coping strategies should be implemented by means of our interventions as health professionals, but also trying to find out some more practical ways to help our beneficiaries. Sorry. So we had three hypotheses before starting to conduct our research. At first, we thought that caregivers of people living with dementia will be more likely to report increased levels of emotional function. And when I'm talking about emotional function, I talk about emotional management, experience, and stress levels. More likely to report increased levels of negative thoughts and adaptability. And according to the second hypothesis, caregivers who received support during the quarantine imposed will be less likely to report increased levels of course, these variables I mentioned previously. And according to the third hypothesis, caregivers of people living with dementia will report that the quarantine affected their care of people living with dementia. I will not focus more on materials and methods because they are all described in the published paper. We took caregivers and also people matched to age, educational level, and gender. Match controls, 303 was the sum of our data sample. Here you can see the duration, and also we divided our caregiving population in two subgroups. The first attended our supportive groups, of course digitally delivered, and the other ones did not attend. Of course, we didn't make any distinction or any exclusion. It was their own willingness not to support. Of course, we designed the exclusion and inclusion criteria clearly written in the paper. And we designed an online questionnaire, which includes self-report questions, and we spread it via Google Forms. We advertised the research through our social media and, of course, through our supportive groups for caregivers, mainly CBT sessions, family therapy groups, and, of course, psychoeducational groups who have variety groups delivered in our daycare center and specifically in our unity of caregivers. Here you can see those groups which were digitalized even during the first quarantine imposed in 2020. Here you can see we had psychoeducational sessions, a family support group, and also we had relaxation techniques, all delivered digitally. What is very significant is that our online groups, especially the psychoeducational one, was similarly efficient according to the on-site group because we did a research previously to the pandemic and published during the pandemic. in 2021. And according to this paper, we found that both online and both on-site programs were efficient and were able to produce similarly beneficial benefits by means of reducing caregivers' burden, depressive symptomatology, and anxiety. I want to also focus more on the statistics because we don't have enough time. If you see the paper, you will find out all the demographics of our study, clearly differentiated by means of whether caregivers participated in the supportive groups or not. And I think that the more significant part is to see the results. It seems that caregivers, irrespectively of whether they participated in supportive groups, had higher levels of stress as measured by the Beck Anxiety Inventory. It was not about their self-reports. It was the only question measured by an objective test, an objective scale. And additionally, it seems that caregivers self-reported that were less able to manage their emotions in comparison to the control group, and also it seems that those who participated in our supportive groups mentioned that they were less able to manage their emotions. However, in contrary to the contrary of our hypothesis, it seems that caregivers, irrespectively of whether they participated in our supportive groups, mentioned that they had lower levels of sadness, frustration, loneliness, and hope during the quarantine imposed, because they said that we also live this type of restrictions during our daily life, so no many changes observed during the quarantine. And additionally, another unexpected finding is the fact that those who did not attend supportive groups said that they had less level of agony and loneliness compared to those who participated, and we will discuss about it later. So, to sum up, we found that caregivers were significantly more likely to report that it was more difficult for them to manage their emotions and also their stress levels by means of BAI scores were increased. So this was in line with our first hypothesis. The second finding is that caregivers had reduced levels of sadness, frustration, and loneliness and hope, which is in objection to our hypothesis. We were expecting to find just the opposite, that older adults who are not caregivers would have reduced levels of these emotions and increased hope. The third finding is that caregivers from supportive groups had increased levels of agony and loneliness, which is also in objection with our initial findings. According to some other results, we found that half of them, the caregivers, irrespectively of whether they attended supportive groups or not, reported changes due to the quarantine during their daily life. Additionally, no differences were observed by means of negative thoughts and adaptability skills, which also some other hypotheses made in our research design, but the only things that we should focus on is emotional function and not cognition or adaptation, according at least to our results. So here you can see that caregivers mentioned, half of them, that there was a psychological effect during the quarantine to them, and half of them said not. Here you can see the percentages in the table, also clearly described in the paper. And what is very, very significant is that those who mentioned that the people living with dementia deteriorate deteriorated due to the pandemic were less able to manage their emotions, had more fear and stress symptoms, and also reduced optimism. So it's not that all caregivers had problems with their negative experience during the pandemic. The most significant thing, according to our results, is that those who had increased burden is those who mentioned that the person living with dementia deteriorated during the pandemic, which is really significant fact. In conclusion, I wrote them in that way, like questions, in order to take some take-home messages. Caregivers of people living with dementia differ to the healthy controls who are not caregivers by means of emotional management, because they self-reported that had reduced emotional management. So this is in line with our hypothesis. However, caregivers of people living with dementia reduced levels of sadness, frustration, and loneliness and hope, which is in objection with our results. Caregivers of people living with dementia differ to their peers by means of stress symptoms, which was also predicted by our hypothesis, and as about negative thoughts and adaptability, no clear results can be made because we didn't see any other type of studies published for this variable, so it is still under question. So those who attended supportive groups had increased self-reported emotional management. Okay, we were expecting this finding, but had also increased self-reported negative emotions, specifically agony and loneliness. So probably this is the reason why they decided to participate in our supportive group. So the others didn't have this kind of emotions at a large percentage, and probably this is the reason why they didn't want to participate. But it's very significant to highlight that a severe variable describing caregivers' negative experience during the pandemic is the person living with dementia deterioration or not. I think that this is the predictor about their negative experience. So, taking into account that we should focus on further initiatives, you can see here our future endeavors, for example, to use other objective measures except by scale. Of course, it would be really nice to increase our samples, and of course, the take-home message, at least by our team, is the need for implementing supportive groups for increasing emotional management in future lockdowns or any other home restrictions. And of course, here it's significant to identify the role of resilience, adaptability, and perhaps positive thoughts. But we can't say something else about adaptability because we didn't find anything. So thank you for your attention, and if there are any questions, I'd be happy to answer.
So there's a question. I have one. This work takes a clear picture of the Greek society during pandemic. I'm trying to make you a guess, but do you think that a more inclusive society, like dementia-friendly communities and so on, could have changed the result of this work? Mm-hmm.
A dementia-friendly society by means of further activities before the quarantine. Okay, because this is the motto. Actually, yes. It seems that activities accomplished before the pandemic can be a predictive factor for what is happening during the pandemic. However, these caregivers did not participate in, referred that they had a restrictive daily life life. But I don't know, or any other member of our research team, whether it was their choice not to participating in these opportunities and activities, because in a Greek Alzheimer Association, okay, I come from Thessaloniki, we have many other associations in Athens, Patra, Crete Island Roads, and so on. We deliver many kind of activities and dementia care services. So I think that we should focus more on whether these people are reluctant or have problems to participate, which is part of generally the health system, and if they are available to take part in these activities, irrespective of whether they exist or not, because they exist.
Wonderful, thank you. You answered my question correctly. Thank you. Our next speaker is Jennifer Hall. She's from University, from Alzheimer Scotland. She will talk about technology, a trauma-informed approach to health practice. Thank you.
Thank you so much for this opportunity. Thanks to Alzheimer's Europe for allowing me to share with you some insights today on the work that we've been doing at Alzheimer's Scotland. Alzheimer's Scotland is Scotland's leading dementia charity, and we support people living with dementia and their carers across the country. We have both national and local support that we provide, and we are at the heart of what we do. We're a voluntary organisation. The work that I'm going to share with you today is actually a partnership that we embarked on with our wonderful colleagues at the Centre for Policy and Practice at the University of the West of Scotland. And the piece of work is around a trauma-informed approach to helpline practice. So I want to start by acknowledging and thanking my friend and colleague, Dr. Margaret Brown, who's unable to join me today to talk to you. But her knowledge, her expertise and her passion for this topic has been absolutely inspiring and invaluable as the project's evolved. I really don't want to spend too much time reflecting on the point at which Scotland went into lockdown back in March 2020. It was a harrowing and a traumatic time for everyone across the world. We all experienced it to some extent. However, it's absolutely crucial and important that we acknowledge that people with dementia and their carers were and they continue to be disproportionately impacted by the COVID-19 pandemic. When Scotland went into that first lockdown, there was extreme disruption to our health and social care services, and with that, the reduction and in many cases the complete withdrawal of life and limb support. That might have been in the form of daycare and home support and been able to access primary care through our GPs, but all of that was completely up in the air and totally disrupted. Not to mention the disruption to people's daily routine, which we saw and we understand now exacerbated people's symptoms of dementia. And again, sad to say that we are still experiencing the impact of this 2.5 years down the line. What button do I press here? Sorry, just to move my slide on. Is it this one?
No, the big green.
The big green one. Should have asked that to begin with. So in terms of identifying a need, as I say, Alzheimer's Scotland is a local and a national organisation. We campaign for the rights of people living with dementia and their carers. We aim to influence policy and we aim to address some of the gaps that exist between policy and practice. But for over 33 years, Alzheimer's Scotland has offered the Dementia Helpline. This service is provided exclusively by a team of highly skilled, dedicated volunteers who operate remotely from their own homes, ensuring that there's always someone available at the end of the phone, 24 hours a day, 365 days a year, ready to listen to those that need us. And our helpline was the only service that was left undisrupted by the pandemic because it was already perfectly set up to deliver that from home. So in real time, we were hearing from people about that lived experience and what was actually happening at that point in time. So as I say, the helpline provided a lifeline for people over the years who depended on us, often a first point of contact for people living with dementia and their carers needing support. Our helpline offers emotional support, information and signposting onto other sources of information and support where appropriate. But in March 2020, when our country ground to a halt, Dementia Helpline remained there for people who needed us. But very quickly, we began to feel the pressure and the demand as the demand grew on our service. We had always experienced a steady demand for the helpline, and it was always manageable. Nothing could have prepared us for what we were about to experience over the course of 2020 and now into 2022. So just to give you an idea of identifying the need for that trauma-informed approach, there was an increased demand on the helpline, so we experienced 30% increase in calls, and there was also a huge 80% increase in the length of time that volunteers were spending on the phone supporting and listening to callers. And I think that in itself is quite revealing in terms of the level of emotional support that our volunteers were providing at that time. The Dementia Helpline has always aimed to empower callers by, providing that level of support. However, the level of distress that we were hearing from our callers gave us huge insight into what that lived experience was like within the dementia community at this time. And it felt like we had transitioned almost overnight from a helpline where the demand on us was manageable to a crisis line. And that's really where these conversations started to take place around what can we do here. So just to give you an idea as well of who calls our helpline, we were consistently high level of extreme distress from callers. That was predominantly carer stress that we were hearing. So family members, friends, and often we were hearing more from people that were neighbours of folks that maybe lived with a diagnosis of dementia, but they were living on their own at that time. So that concern that you were seeing from people within the community, so 94% made up that figure, that group of people. Only 4% were people living with dementia and 2% were professionals. Now, interestingly, the professionals that were calling the helpline at that point, they were looking for emotional support themselves. As things were evolving in care homes, we were getting care assistants phoning our helpline saying, really traumatised from the bottleneck that was the PPE, not getting through to people. So they were expected to wear bin bags to carry out, tasks of daily living. So it was pretty horrifying what we were hearing at that time, and people just didn't know where to go for support. So they were phoning our helpline. And that's really where my level of concern came into as the helpline manager at the time. I was acutely aware that the level of distress that we were hearing from people, and also just the concern for the individuals calling, but particularly for the volunteers that were absorbing that. And that's where a colleague, Margaret, she asked this question about, can you walk through water without getting wet? Now I'm quite a visual person, I like analogies like that, but it was just such a kind of turning point in my mind to think about, can you walk through water without getting wet? Is that possible? And the pressure that was on our volunteers at a time where things felt incredibly helpless, was really challenging. So I wanted to make sure that we were doing as much as we could to support our volunteers and to support our callers, and keeping everyone safe in the process. So that experiencing that unprecedented and traumatic time, Alzheimer's Scotland not only had a responsibility, as I say, to the callers, but also to the volunteers that were absorbing that distress. And this is when that conversation took place with Margaret, and Margaret felt like the trauma-informed values absolutely were relevant here. And the trauma-informed values, they underpin a lot of what is at the core of our dementia helpline. It's about safety, trust, collaboration, choice and empowerment. All of these are values which, as I say, are at the heart of what Alzheimer Scotland believe and what underpins the helpline practice. And this is where we come to the co-creation of this learning session. So in the midst of all of this, we really wanted to make sure that volunteers were as supported as they could be. And our Dementia Helpline, it has a large team. It's the largest team in our organisation. It's 55 volunteers that deliver that support, and they're supported by a very small staff team. So there's 2 coordinators and myself that's responsible for the day-to-day kind of running and overseeing that. But 6 of our volunteers are actually team leaders. Now, they've taken on that enhanced volunteering role to be there and support the whole team, so as that volunteers, no matter what time of day it is, there's always somebody that they can contact to get additional support. So we worked very closely with the team leaders to co-produce this session where we created a workshop. And the whole kind of principle of this workshop was to allow us to create space and time to connect and explore a trauma-informed approach. And there was a lot of conversation about the word trauma and what that means. You know, it held different meaning depending on your perspective, but it was absolutely relevant at this point, not just because of the trauma that COVID was causing people, but also it was kind of the bubbling up to the surface. There was a lot of traumatic experiences in people's lives that they maybe reflected at that time and wanted to discuss, and really recognising it for what it was, which was, you know, the experience of trauma. To examine early trauma, current trauma for the person affected by dementia as well. So, you know, getting a deeper understanding of what that experience might be like and how this can be, you know, really valuable in that exchange. And to explore personal and organisational trauma-informed approaches. So really we were wanting to look at how do we make people feel safe? How do we enhance trust? And how do we partner with that person in that brief exchange, often on the helpline, where it is just that one point of contact, but there's an opportunity there when taking helpline calls. So we co-created a robust awareness session for the team around this, and it was very well received by volunteers. And I think that one of the things that made it so successful was that idea of, you know, the co-creation. We worked alongside, you know, equal partners with the team leaders there to make sure that this was relevant, that it was hitting, you know, the mark in terms of being valuable and worthwhile for volunteers. So this is just some of the feedback that we had from volunteers. So you know, there was one that said it was very informative and it already influenced their calls. Yesterday she was able to speak to a caller whose husband is in a care home and has been very frustrated, lashing out at staff. We spoke about what might happen when he wakes up and sees a carer in his room. It was good to be able to do this rather than make more general suggestions like chat to the staff or speak to the doctor. So volunteers were reporting that they were feeling that the exchanges they were having on the helpline with callers at that time felt more meaningful, and that they were able to influence and offer suggestions that held more meaning and purpose by applying that trauma-informed lens. Another volunteer said that this really puts into context what trauma is and what trauma-informed practice is. I have made so many assumptions in the past where a trauma-informed lens would have been so helpful. So definitely going to be keeping up at the forefront of my responses. Sorry, I need my glasses. So yeah, that was one of the kind of bits of feedback from another volunteer. And again, just going back to understanding and looking more in detail at what do we mean when we use that term trauma. Thank you so much for enabling me to join the session. So worthwhile, even on a sunny Saturday morning. Really enjoyed it and found it useful. Margaret explained all of the things very clearly, illustrating examples from her years of experience. And finally, a volunteer said, excited. Maybe this doesn't sound like the most appropriate word, but it is a new tool in the helpline toolbox, which I can use responding to some of the very challenging calls. So just some reflections there from our volunteers who have found this to be a really worthwhile opportunity. Because of the nature of the helpline and the fact that we do depend on volunteers to deliver that service, the absolute least we can do is give them what we have to prepare them for what they're going to hear on the line. Over the last couple of years, there has been a shift, in the helpline calls, particularly in what we're hearing in terms of the level of distress, and also the fact that we do in Scotland have a very fractured health and social care, system. It's on its knees, and I think it's fair to acknowledge that and to say that we really need to, have wider conversations about how we get this right. But going forward, for people that are phoning our helpline, they can be guaranteed that Alzheimer Scotland will strive to be a trauma-informed dementia helpline, because this is a fundamental part of our training now and what we're offering volunteers, because it has just been so helpful, you know, and significant over that time. And also some early findings from the Triad study. Some of you might have heard from my colleague Eileen Harkis-Murphy, who spoke yesterday, but she led the Triad study, which was kind of a bit of evaluation, looking at a cross-section, 200 call records over that time, to really see how volunteers were implementing a trauma-informed approach to helpline practice. And those findings were really encouraging, because what we were seeing is that, you know, overwhelmingly what our volunteers are doing are ensuring that they are empowering callers with knowledge, with information, making sure that choice, collaboration, trust, all of those things are at the forefront of their minds and at their responses when they are speaking to callers. So there is, you know, there's a lot of work around trauma from what I understand. I am not an academic, but I do know that it's pretty sparse what is available on dementia care and trauma. So I think there's loads of opportunity there to look at, you know, how that can play a part in kind of contributing to that evidence base as we go forward. So I'm really excited to see where that takes us. But thank you so much for listening to me today, and I'm happy to take any questions.
Thank you very much. A question over there?
Thank you for your presentation. I have a small observation that might be a question for you, but also to Clarissa and Marianna. You talked about the helpline becoming a crisis line, and that happened in home care and in nursing homes as well, of course. What I heard in Antwerp is that home care organizations reached out to Red Cross International and to Médecins Sans Frontières, who were used to crisis situations, who were used to fighting infectious diseases, who were used to fighting traumas, and who were used to communicate with vulnerable people while wearing protective gear. Is any of those links with those international organizations have been made in your situations as well? Because I heard that they were very, very useful for dementia care staff.
I think that's a really good question and a really important point, because what we found ourselves in was that emergency situation. You know, it was unprecedented. None of us really knew the right thing to do to respond in that situation. So, you know, and I think that's where the link between trauma-informed practices became so relevant, because trauma, it's kind of emergency, it's responding at that point in time. So that is a really good suggestion for us to make links with the Red Cross, who we do have you know, close kind of relationships with anyway. So thank you for that. I don't know if Clarissa maybe has...
Good question. It didn't come up in our research, but I know that Professor Adam Gordon from University of Nottingham has been involved in setting up a WhatsApp group for care home managers towards the beginning of the pandemic, which is still going, and they were all kind of supporting each other with questions they had about different issues of supporting one another. So that's been a good project. Yeah.
Thank you very much.
Thank you.
Our next speaker is Duygu Sezgin, sorry. I'm Italian, so from National University of Ireland, Galway, Ireland, of course. She will talk about a mapping exercise on the uptake of technology among people with dementia during COVID-19 times. Thank you.
Thank you very much. Okay. Hi, everyone. My name is Duygu Sezgin. We recently rebranded, actually, the university's name changed to University of Galway. So we are based in Ireland, from the west coast of Ireland, and I'm a lecturer there. So today I'm going to present my work about a mapping exercise. Sorry, I'm too close. A mapping exercise to look at the technology, more specifically digital technologies used in different projects or initiatives during the pandemic involving people with dementia, and some of them focusing on their caregivers, including their caregivers. So we did this work as part of, should move to the next one. This is a work of Interdem Special Interest Group of COVID-19, but before I go into details, I'll just talk about, I just want to highlight how important it is, and it was even before the pandemic, that the involvement of technology, specifically digital technologies in the care of people with dementia, to enhance their social health and participation. It has been increasing even before the pandemic, and this uptake has further accelerated after the start of the pandemic. But we don't know well what kind of projects they are. Are they research projects? Are they other kinds of initiatives? And who is leading them? Or the nature of these digital technologies involved. So that's why we wanted to look at the evidence out there during the pandemic. So the Interdem, which is a pan-European network of researchers collaborating in research and dissemination of research about people, about psychosocial interventions in dementia, aiming at improving their quality of life of people with dementia and their supporters. So this group came together, a special interest group about COVID-19, and we called our work UTech-19. So there were different tasks involved within this project, and I'm going to talk about the mapping exercise part of it, and after my presentation, Anna will talk about a rapid review. So what we did for this mapping exercise, we wanted to identify some projects, not necessarily research projects, it could be local initiatives, involving the use of digital technologies for people with dementia. And we didn't specifically limit it to certain type of technology. We kept it generic, we kept it broad to gather as much of evidence available. And these are the inclusion criteria here. The project or initiative had to be conducted by members of Interdem and or their professional networks. Should have involved people with dementia during the COVID-19 pandemic, and should have should have involved digital technologies. For data collection, we used an online surveying platform and sent out the link to Interdem members. Due to low response rate, we had to extend it to the network, people who are in contact with the members of the Interdem network. Could also respond to the survey, and we collected our data during December 2021 and around mid-March 2022, approximately 3 months period. So they responded to the survey using the link. We also promoted the survey on LinkedIn to get more responses. To analyze data, we used qualitative and quantitative methods just to look at the simple descriptives of the data. And also we used the framework to map the technologies we identified using Myland et al.'s framework. And the mapping was performed by 2 members of the team, and then if there were conflicts between the team members, we just resolved them with discussion and consensus. So looking at the results, despite our efforts to promote the work and despite the reminders, we only got 48 responses, and 31 of them were fully completed. And as I showed the inclusion criteria earlier, some of them didn't meet the inclusion criteria, so we had to go through all of them, and 28 projects qualified for the study. When I say projects, this involved 21 of them were research studies and 7 other initiatives, not necessarily identifying as research projects, but they were just initiatives delivered at local or at the level that involved multiple organizations. 24 of them were from Europe, and 12 of them, so most of them came from Europe, and half of the data came from Europe, came from the United Kingdom. So these are the countries where respondents reported the study from. But for example, 6 of them were run in multiple countries. So we asked them several questions. For example, was the digital technology the main method to deliver the intervention? And 23 of them said yes. More than half said they had to change their intervention to a digital technology because of the COVID. And when we asked them when this change happened, it was around the early stages of the pandemic, so March, May 2020. If you look at the time period, some of the projects started way before the start of the pandemic, but they were still ongoing, and they had to make this change, so convert to a digital intervention because of the pandemic and lockdown. Some of them indicated that they don't necessarily have an end date, and they were also asked if the project was ongoing when they were hoping to complete the project, and that was reported as a wide range, really, July 2022 and January 2024. So that's very small. I hope you can see it. We looked at the details of these projects, who delivered, and this is the information about PI. Most of them were delivered by professionals with a background of psychology and clinical psychology. The following one is researcher/PhD student. They didn't specify their professional background, but also this is followed by the nursing professionals from nursing area, and the setting was mostly from home, and then community and care home, not surprising. And the sample size is really, there's a big range here. So those that had dyads, they reported the numbers there within the group. They had the person with dementia and their support person. And other dyads were person with dementia and professional caregiver. As you can see, on average, it's 32 or about 30, but there's a big range, really. Projects where they didn't have dyads, total sample size reported. Again, a very big range there, but overall total sample size came from the studies was over 1,000. Some more details about whether they were funded or not. Yes, 18 of them out of 28, they received funding, 8 being the national funding, and more details such as 8 of them were already published, and about 11 they expected to publish, and only a few just mentioned it's just a local initiative and they had no plan of publishing their work. So when you look at the people involved, the characteristics of the participants, most of them, so for this question they could choose more than one answers, most of them were mild or moderate dementia, and only 9 reported they involved people with advanced dementia. And this is about the involvement of people with dementia and or their caregivers in the planning and delivery of those projects. It looks good here because for both charts you can see people with dementia or their support persons, they were involved in half of those reported projects. They were involved in the design of the projects, and they reported other forms of involvement, such as providing giving feedback and being involved in the consultations. So that looks promising. And when we look at the data, so this is a cloud map, came from all the interventions reported or how they delivered their projects. As you can see, Zoom is in the middle, so they mostly used virtual platforms for communication. That was very dominant in the data. And they used these platforms to remain connected with their informal networks and also with their caregivers. And the few other examples we found, such as sensor technology, social robots, or some mobile applications or websites, they were also used during the pandemic. Now, looking at this framework we used to categorize the interventions overall, according to Mailand et al. So first category, we don't have many under this one. It's about devices and platforms and technology to help people manage their everyday life activities. And the second one, I will show you some examples, but we don't have time to go through all of them. The second one is about technologies to help them to engage in meaningful and pleasurable activities. So about 19 of them fell into this category. So this was well delivered during the pandemic. And the third one is about people's communication with the caregivers. Some platforms, so some examples here. The first one is about supporting people with dementia for their everyday life activities. Only 5 of them were grouped under this category. There were some overlaps. For example, some projects could fit under 2 categories. The first one is called a website about co-designing dementia, so post-diagnosis support website. This was reported as something happened during COVID, and they were active. And the second one was about a research project and stakeholder involvement about supporting them for over 90 plus, for more than 90 everyday activities, including a mix of analog and digital devices, such as touchscreen computers or some special microwaves. So that's an interesting one. And the second one, this is the category where most of the projects fell into. So this included large, different interventions, such as singing, such as music therapy, culture box, delivering them packs of information so they could get involved in some creative activities, and also a project about virtual individuals cognitive simulation therapy. So these were, we categorized them under this one. The second one, to help them engage in meaningful and pleasurable activities during COVID. And the last one is about care technologies to support them to contact with their professional caregivers, healthcare and social care providers, for example. Typically, this included video conferencing tools so they can remain their contact with the professional caregivers. Mood science is another one that's an example reported here. It's about use of smart sensor technology, so they could detect some challenging behavior or early signs of deterioration, so they could pick that up. So these are the examples, and because most of them aren't published, I could only gather the information as reported by the participants, but for some of them I could put the links there, but hopefully we will hear about these projects more. And maybe some of the projects already mentioned here yesterday and earlier today. So to sum up, really, what we looked here, we wanted to identify what's going on during the pandemic, what kind of projects, research, initiatives happening, and wanted to find out who's involved in delivering them, what kind of, the nature of these projects, and I can say they were mostly about online communication technologies, including video conferencing platforms. That was very dominant in our data. We could conclude that people who received these interventions, they remained connected with their informal support groups and also with healthcare providers or social care providers. So that shows that there was support available. The other thing positive here, people with dementia and their caregivers, support persons, were involved in these projects, initiatives since the beginning. They could provide their input, that was significant. Anything else? We could aim to have this involvement in those projects using virtual technologies so they could provide their input even after the pandemic, but we discussed here there's positive sides of it and also some risks involved, so we suggest there should be a good balance of face-to-face and online for their involvement in the projects. I'd like to thank here to research team, Introductory members, they provide feedback and provided details about their projects, and also our participants. Thank you very much. Happy to take questions.
Are any questions from the floor? I have just a quick comment. What do you think technology will leave us? I mean, yesterday Professor Kurt talked about building bridges between scientific project and the reality. It should be interesting to understand better how those projects that you showed us will do in the next 2-3 years after the pandemic. What do you think?
If you mean that, will we continue using this or not?
Yeah.
Was that these are the projects, some of them even started before the pandemic using the online technology. So some of them had to convert to online so they could deliver the intervention, otherwise no way they could deliver the project. So I can imagine that there was a bridge already built between the care providers and people with dementia and their professional or informal caregivers. So technology provided a bridge to make this sustainable. Maybe some of them will remain, but some of them will prefer going back. I think we need a bit of both. We need technology, and we learned from the pandemic that we can use it in a good way to remain our contact with people with dementia, to support them. But we should always be careful about this, because earlier it was discussed that sometimes it's easy to go for the online one because it's cheap, it's very practical, but we could look at what they prefer, what works for them. That's a very important point.
Thank you very much. So, our next speaker, after talking about the mapping, we will talk about looking to the evidence of the use of technology. Ana Barbosa will talk about that. She's from University of Bradford, UK.
Sorry. Good afternoon, everyone. So my name is Ana Barbosa. I'm an assistant professor at the University of Bradford, and I'm also a member of the INTEDEM Task Force on Assistive Technology. It's nice to see some people from that group here, some of our members here. And the project I'm presenting today is part of a project that we've done in INTEDEM, Task Force on Assistive Technology, and builds on what Duygu just presented before. Basically, what I will present is the findings of a rapid review on the use and uptake of technology by people with dementia and their supporters during the COVID-19 pandemic. So just a brief background. We were all affected by COVID. It changed our routines. It changed the way we interacted with people. The support that we had available stopped. So we know that in the last 2 years, there's increased evidence that COVID and related restrictions had a massive impact on people living with dementia. And we heard this today in the morning. This was the population most affected by COVID. And technology became key during COVID. It helped a lot of people to be independent in their own homes, helped to allow them to be more sociable. So technology was really important during the pandemic. But at the time, last year, we didn't know much about what kind of studies were being developed during the pandemic, what technologies were people living with dementia using, and what's the impact of these technologies on their life. So that's what we try to do with this project. We call this UTech 19, which stands for the use and uptake of technology by people with dementia and their supporters during COVID. And it consisted of 3 steps: a rapid review, which I will present today, a mapping exercise that Duygu just presented, and then the idea is to gather all this evidence and develop recommendations for practice. And we worked with patient and public, so we had patient and public involvement in this project. We worked together with 2 experts by experience, Nigel and Helen, from Alzheimer's Europe Working Group on Dementia. And they were very active in all stages of this project, including on this rapid review. So why a rapid review? As the name suggests, it's a review that is conducted in with brief timescales to be done as quick as possible. And that made sense to us because COVID happened 2 years ago. And hopefully we're not going to go through another pandemic, and we will in the near future be all fed up of COVID, and we don't want to read more about COVID in the near future. So we wanted to have something published and accessible now, right now, because that's what makes sense now for people to know. And that's why we've done a rapid review, to make sure that the information that we provide is not outdated. So the main objective was to explore how people with dementia and their supporters have been using technology during the pandemic. So we were interested in the type of technologies, what impact the technologies have on people with dementia and their supporters. And by supporters, we mean informal caregivers, so family and friends. How has the uptake of technologies changed during the pandemic, and what facilitators and barriers affect use of technology? So in terms of methods, we search in a range of databases, PubMed, PsycInfo, Scopus, Cochrane reviews, by people living with dementia, but we also include people living with mild cognitive impairment. We know that several people will not progress to dementia, but we wanted to cover a broad range of literature, so that's why we included people living with mild cognitive impairment. And we also search for studies focused on supporters. Technological devices, so computers, tablets, we didn't search for basic aids, daily life aids like wheelchairs or those kind of things. We were not focused on. We're focused on digital technology. And because we are an international group of people, we search for published studies in English, Spanish, Portuguese, and so on, to cover a range of studies from different countries. And again, we search for a range of studies as well. And despite the fact that this was a rapid review, we were very systematic as well. So one person done the first screening, and then two people looked at the full texts and gathered the data from the full texts. So it was really a teamwork approach. And we've identified originally 379 studies, but we end up with 18 studies. And again, the team came together to extract the data from the studies. So very quickly, key characteristics of the included studies. Mainly conducted in 2 countries, United States and United Kingdom. Most of them, so 15 out of 18, cross-sectional and conducted in the community. Qualitative studies, they dominated. So 8 studies, fully qualitative, and 3 mixed studies. 2 studies conducted with supporters only, so most of the studies were conducted with people living with dementia only. We also noticed limited public involvement. So only 4 studies reported involvement of experts by experience, and by this I mean people with dementia and supporters in their studies. And they help mainly with data collection tools. They help to develop the interviews, for example. And interestingly, as I said, we worked with experts by experience in this review. And they, when we were discussing the results, they said that researchers were lazy. They could have involved people in their studies, because during COVID they were really active. They were involved in all sorts of studies, so it was possible to have more public involvement than the public involvement we found in the literature. Most studies didn't report a type of dementia, so only 5 done it. And 4 of these were focused on MCI, so mild cognitive impairment. We've assessed the quality of the studies. They were mixed, they were small studies, not very robust, but obviously those studies were conducted during the pandemic. There were a lot of challenges, so we need to look at these results with a critical eye. So, type of technologies. What technologies were used by people with dementia and their supporters? We've organized the technologies using this framework by Carretero and Lawrence. So technologies could be organized by technologies for memory and self-care, so like reminders or clues. Technologies for treatment and interventions. So, for instance, cognitive stimulation delivered online, or robots. The use of robots. Safety and security, so this includes sensors, like fall sensors. Training, so online education, usually for caregivers. Care delivery, which includes telehealth, telemedicine, so delivery, remotely delivery of care. And then technologies that aim to improve social interaction and networking. So we found that studies, the 18 studies, were focused on 3 types of technologies: treatment and interventions, care delivery, and interventions that aim to support interaction and networking. So 6 of the technologies were under this category of treatment and intervention. So we had pet robots, which were associated with increased socialization, reduced loneliness and anxiety. A robot-assisted cognitive training, which seemed to have reduced depression, improved language production, memory and attention. Online cognitive stimulation training, so we had 2 studies under this category. And interesting here is that these 2 studies didn't find any difference between online delivery of the intervention and face-to-face delivery. And then for supporters, we only found, as I said, 2 studies focused only on the supporters, and they were online support groups for supporters, and they were associated with improved emotional well-being, reduction of social isolation and loneliness. And then we had 6 studies focused on remote consultations, so interventions that involved use of video or phone to receive care. They were generally well accepted. Participants seemed to prefer video to telephone. It was also noticed that not many people living with dementia were able to use these technologies independently, so they needed as supporters to help them use these technologies. And finally, 3 studies focused on interaction networking, and these were mainly the use of phone and, again, Zoom and other video conferencing tools. They were generally accepted, but as someone mentioned in the morning, virtual connections do not feel the same as in person. Uptake of technologies. We only found 2 studies that compared the use of technology before COVID with during COVID. Not surprising, they both reported more digital contact between people with dementia and supporters. But when asked if they were interested in technology, most said that they were not very interested in technology. In terms of barriers and facilitators, 2 types of barriers and facilitators. Those related to the technology itself. So it provides, it's convenient, time efficiency. It helps people to be in contact in an easy way, and obviously cost savings. People don't need to travel to see each other or to get support. But a lot of barriers associated with technology. Poor internet connection, limited access to technology, the emotional impacts of some of the technologies, so this was specific to the use of robots, impersonal care delivery. And then we had individual related factors. And here the barriers outnumber the facilitators, so we had a lot of barriers identified. So people not being familiar with the technology, lack of literacy, digital literacy, visual impairment and cognitive impairment, which makes things a bit more difficult. Lack of interest, as I just mentioned, people are just not that interested at all in technology. And the need to rely on supporters. And for supporters, an increased burden, because they had to understand how to manage technology and support the loved ones. So in terms of conclusions, we had, of course, limitations with the studies, limitations with our review, but it seems like most studies conducted during COVID were focused on already accessible technologies, low-cost everyday technologies. We didn't find any study focused on a new technology for people with dementia, so they were using technology already available and repurposing them to help manage the negative impact of the pandemic. Technology seems to be well accepted, but it's associated with a lot of barriers. Also, some positives: improved mood, social connectedness. But yeah, as I said, there's a lot of barriers, and these barriers don't seem to be that different as the ones we found in previous studies, so before COVID. So it just means that we still have these barriers and we still need to do something about it. Most studies targeted people with dementia living at home. Again, it's not surprising. It was very difficult to do research in care settings during COVID, so this is not a surprise. And the severity and type of dementia were rarely mentioned. And we know that specific types of dementia have obviously specific impacts. I was thinking about posterior cortical atrophy dementia that impacts on vision. It would be interesting to understand how this type of dementia affects the use and uptake of the technology. Take-home message, pandemic has fast-tracked the adoption of technology, but we know this will continue, and we know we need to do and to be involved in more research. We need more studies focused on design and implement technologies tailored to the needs of people with dementia, particularly to those living at different stages or living with young onset dementia, people living with sensory loss, visual and hearing loss, people that live alone, that don't have easy access to technologies, people that don't have anyone to support them. So what can we do to help these people? And we also need studies that ensure that people with dementia are enabled and empowered to use technology. We found out that most people struggle to use technology themselves and they needed a supporter. So we need to ensure that technology can empower people to use them. So just the studies including Giebel as well, and our team. So thank you for listening, and thanks for the team.
Thank you. Do you have a question from the floor? Just one.
Just quickly, first of all, I'm a Mark Abbey GP professor at Liverpool. Pandemic and its effects are not going anywhere for quite some time. We're going to have to adapt to them. The austerity is bringing worldwide, and until everyone is vaccinated worldwide, a form of COVID will be around, and its effects will be going for some time. I want to tie together a few things very briefly. The pandemic has shown us that public involvement has been enhanced for some people who found getting to face-to-face meetings difficult for various reasons. But the technology is just not up to it for people living with dementia and their carers. And we should be talking to the Davos people. I think your last point was really important. The people who build the technology really need to engage with people living with dementia of different types and at different stages and their carers to make sure it's fit for purpose, because it isn't for most people. And the world of digital technology for social care support is littered with nice bits of kit invented by young things, not talking to the end user, that go into a drawer and gather dust. And if we want to make it accessible, we really need, as a movement, to be working with those manufacturers and saying, can you please co-produce kit for people living with dementia that enhance their lives and don't just bring you money in and gather dust in the drawer and make their life worse. Because the problem is that the policymakers will assume that technology is there for consultations and for care at a distance, and it's not fit for purpose for many people at the moment. So.
Yeah. Thank you so much for that comment. It's a really important point, and we know from my experience as well, people struggle with online conversations. People with dementia struggle with using digital technology and with online conversations. And I said, with specific dementias, the difficulties are increased. So people with sensory loss. So for us, we probably take it for granted, but it's not. And from now on, we need to really develop interventions that, as you said, include people with dementia from scratch, from the plan to the design to the evaluation. People need to be involved in designing new technology.
Thank you very much. This concludes our parallel session. I'd like to thank all the speakers and you, audience. Thank you very much.